It's fair to say right now that first steps, we have made our first foray into telemedicine. Another step forward is virtualization of healthcare. In our case, we can discuss virtualization of primary care or integration of new technology tools in patient care. Piotr, please tell me, how advanced are we? How far can we go? I think Andrzej has demonstrated that in real life it is happening here and now, and leaders have left, most players behind. Champions of this change are trailblazing. They are shifting our paradigm, and I think we will go as far as we are ready, because technologies are ready to use. The human factor is changing at a much slower pace, and the whole environment, ranging from regulations to habits, force us to adapt technology to the context. Most radical changes that we witness on other markets. We are going to discuss it during a session dedicated to virtualization of healthcare. How to introduce new digital tools to primary care ecosystem. So I would like to invite Andrzej Osuch, who is going to moderate the session. He is Director of Business Transformations at LuxMed. The session will be joined by Nick Guldemont, Leiden University Medical Center, Seshanov First Moscow State Medical University, and the discussion will be commented on and joined by Dariusz Dziełak, Director of the Department for Analysis and Innovations of the Polish Health Fund, Dorota Korycińska, of the Polish Neurofibromatosis Association, and Tomasz Zieliński, Vice President of Zielona Góra Agreement. Andrzej, the floor is yours. Hello and welcome. It's a sign of the times that we are using virtual communication tools to discuss virtual healthcare. Well, this is possible because we have a very cross-disciplinary group of experts whom we've invited to join our discussion. We have to start with the definition. Virtual healthcare or virtual care is a term seldom used in Poland, much less than in Western Europe, the US, or Australia. Well, we tend to use terms defining elements of healthcare. As I was preparing myself for the session, I have agreed with panelists our shared definition, and as the session continued, we will present and use the broadest possible interpretation of this term. Virtual care stands for all healthcare models driven by modern technologies. So some of these activities will be pursued in traditional healthcare establishments, but going digital provides us with new tools, e-consultations, which may be perceived as a part of the traditional healthcare model, but self-diagnosing tools, self-care tools, these are tools contributed by modern technology. So virtual healthcare are overall activities, and there's no better way to define the healthcare model than its evaluation. Evaluation in other spheres of life can be driven by certification or assessment systems, and there are no such systems in place, established systems in healthcare. I think the first comprehensive system was created by WONCA, the World Association of GPs, represented by Nick Guldemont, and I think it's best to begin with presentation of this system. So I'm going to ask Nick to outline the concept of assessment of virtual systems.
The virtual stage is yours.
Dzień dobry. So I will continue in English. My Polish is not yet that good. So thank you very much for the invitation. And I will talk a little bit about the role of digital platforms in strengthening primary care services and the work we have done on assessment and certification in this area, and also by use case of one of the largest digital platforms in the world, which is in China, the Ping An Good Doctor, with over more than 300 million users per annum. Let me see if I can control the slides. Next slide, please. Yes, very good. So the roadmap for the talk is a little bit background, has some words on digital health service platforms, the use case, and the evaluation, and eventually some conclusions based on our case study. So as an introduction, so we already for many years, we forewarned governments on the challenges we have with healthcare systems. Had this related to aging, the rise of chronic conditions, a sharp rise in care needs, and also what we experience also today is lesser resources. We have less people available for providing this care, and also financially, due to the credit crisis, we face serious problems with also debts on a global level. So already we saw that healthcare systems becoming quite unstable, also before the healthcare crisis. So we have these pandemics, which we also forewarned governments in working more together on monitoring systems, on collaboration for developing vaccines, etc. But yeah, as we know, healthcare systems are quite inert. And usually when the problems are really there, policymakers start to make some actions. So here you see an example from the UK, but the same can apply for the Netherlands, that every winter we see hospitals, or at least in some settings, hospital overflown. People in corridors, ambulances waited outside, come deliver the patients. The social care can't receive patients after discharge because the social care is overworked and overloaded. So throughout the years, you saw the same sort of pictures, which didn't really create the sort of urge to really change or improve in this respect. And the Netherlands and the UK is no exception. It applies to many other countries as well. So now we are in a crisis, and due to this crisis and the situation, you see a sharp rise in the uptake of digital solutions in different sectors. Had to work around the lockdowns and for the isolation purposes. And so you saw this in different sectors, and also in healthcare you saw an increasing uptake of mainly digital communication tools in healthcare. But although everybody is very enthusiastic about this rise of uptake of communication solutions, it's not the same as the real solutions we need in healthcare. In telemedicine, in digital health, we have very good examples on how it could work and could help with mental health problems and delivering care. Same with cardiovascular diseases, diabetes, etc. And also to use digital solutions for consultation, online monitoring, and self-management. We have wonderful best practices. But it's not the same as what you need for taking care of people with chronic conditions over throughout the disease process. So coordination, planning in a sort of logistic process over time, you see that most of the digital solutions available are standalone solutions. The same as often healthcare systems are fragmented from a service perspective, the same you see in data and in technology, in digital. So it's very much fragmented, and this fragmentation prevents from what we need to cope with these challenges in providing good care at lower cost with better outcomes. So, and here you see a sort of diagram as a sort of illustration that if you really really want to achieve a better care for people, you need a sort of integration of technology, of services, alignment of policy, etc., collaboration, coordination. As you see here on the vertical axis, where you see the sort of levels of integration when it comes to collaboration and information sharing. And although well-developed healthcare systems such as the Netherlands have wonderful hospital systems, they have top-notch technology available, well-trained doctors, etc., the level of information sharing is at a lower stage. There's a problem. We're still working with faxes, with USB sticks. So the information sharing between organizations, hospital, primary care, social care, and also the people themselves, is often very limited, if not absent. So this whole discussion about big data and AI can't really take off when it comes to real service improvement. And on the horizontal axis, you see the sort of collaboration needed from integrated care perspective point of view, social care, medical care, anything else what is needed to support elderly and people with chronic conditions, which is really the challenge. So you see here really a paradox between technology and innovation and the reality often in healthcare systems. So, and if you think, if your country maybe has the same sort of challenges, that can be true because all over the globe we see the same problem. So we evaluated more than 80 plans on how to improve healthcare, how to work on personalized care or integrated care. So you see wonderful plans with a lot of commonalities in sort of goals and strategies. But if you really look to the successes, they are not so much available. Everybody struggling with integration and real creating value for people. So it is thought that digital health service platform might play a role in integration of services, of technology and data to help people managing their diseases, working more on prevention, etc. So here you see some of the examples. Also in Poland, you have some of these platforms. So this looks quite promising from a superficial point of view. There are different elements. There are some differences between the platforms. But also there are same sort of concerns with these platforms. Because you see also when they talk about how effective they are or how algorithms are used, there's not so much clinical evidence or any sort of evidence which support that the overall service provides better care at a lower cost. So usually you see all kind of innovation, talk of better diagnosis and better assessment, that it better replaces a doctor. But this is only true maybe for a radiograph or other diagnostic procedure, but not the full perspective of a service provision over time for patients. So we can still be very critical on the limitations also on these technologies in service perspective. Accordingly, the World Organization of Family Doctors is dealing with this type of questions on how can we improve primary care, which is a key element to improve healthcare systems, how we can make use of these technologies, and how can we separate fiction from reality. And there are not so much assessment frameworks which looks at the total picture from a service perspective, technology perspective, finance perspective, and a total healthcare system perspective. Accordingly, we developed a framework, but we used one of the largest platforms in the world to see what the framework should consist of, what kind of elements we should include. And the Ping An Good Doctor platform in China has many of the ingredients you saw also in the previous examples of health platforms. And this is typical, a platform which works with algorithms to do the intake, to support the diagnosis, and give recommendation to an online doctor, a physical doctor, in an online setting, communicating with the patient. And so there are a lot of platforms do have this sort of algorithm part and the online doctor part. And if you look to the app, they have a chatbot functionality to filter out the problems of the patient, to build a patient profile. They have a decision support system and also some monitoring elements in place. And here you see some examples of the interfaces for the patient on the left-hand side and for the doctor on the right-hand side. Ping An is typical an organization which is in structure a bit similar to a real hospital. So there are departments which are specialized on certain disease areas. And there's also a primary care department which combine the different expertise needed within primary care. And if you look to their overall performance, self-reported performance, you see that they have a very high satisfaction rate, about 98%. And I should say all the platforms show these type of satisfaction rate. But that doesn't necessarily mean that also the health outcomes are good as well. So the personal opinion of an individual patient is not representative for the overall health outcomes per se. But you see, compared to the China setting, they have a pretty good performance in increasing efficiency and also reduction in cost. Although I should say the real evidence and independent research in this respect is absent, which is quite the same in other platforms. They're all lacking evidence in their performance. So accordingly, we wanted to evaluate these type of platforms, and you start with thinking, okay, what are the sort of basic principles we should include for the assessment? And obviously you start with the guiding principles and value of a given healthcare system. And it's a worldwide organization, so we take in consideration different values of how healthcare should work in a given national context. But there's overall agreement on what a healthcare system should do for citizens. And then you have the sort of service level elements and steps within a system in order to see what goes wrong and what goes well and what kind of criteria you should use. And there are obviously technology and finance aspects which should be included as well. And eventually it should be evaluated according to the outcomes a certain service delivers. So for the development of the framework, we used a mixed method with literature, guidelines, standards. So we made an extensive exploration of all available tools and information in this respect, also organization internationally. And accordingly, we translated this into different domains which we could use for assessment. So we came eventually to 11 domains. And the sort of related process was that we evaluate a platform according to the different domains in a multidisciplinary setting with a sort of independent review process. We apply the norms and criteria related to the domains, and accordingly we can give a sort of judgment on how they performed in different dimensions. And the dimensions we used was, first of all, the comprehensiveness of the provided services. So is this more for a single problem, or is it more for comorbidities, for different age groups, etc., different cultural settings? Scalability is related to how is the service and the platform scalable in a given setting, interoperable, etc. Also, technology aspects are feeding to the dimension of scalability. And last but not least, the validity of the services. So how much is this service assessed according to evidence-based medicine principles, and how much it can prove independent efficacy and cost effectiveness of the service. So here you see a short description of the 11 domains, which is sort of general information on the platform and the sort of business approach towards the market or the population. So what is the intended use of the services provided, for which target groups, for what kind of systems? Is it local, national, continental? What kind of users are currently using these services? What are their needs and interests? There are specific service aspects, the service model, the type of communication used, collaboration between offline world and online world, how the process of intake, the typical sort of medical, sort of clinical procedures, how they are well part of the process. There are, of course, managerial aspects which should be taken into account for authorities. Ethical aspects, the evidence available. An important aspect for many authorities is privacy and data protection. The technology use and the interoperability, algorithms and transparency in this respect. Financial aspects, it means also how the organization has their financial structure, what are the stakeholders or shareholders, is it more public, is it more private, what are the business models, to understand their sort of motivation and market dynamics. Implementation aspect, if you are interested, what are the sort of implementation aspects to be taken consideration. So the framework we applied to this ping-an conductor, we used this type of assessment form, and you see here the different or the 11 domains displayed. You see the domain, the related question as part of the domain, to what kind of dimension for certification, it applies, and we had a sort of traffic light scores had to indicate this was insufficient, it needs attention, or it's sufficient. And also, we formulated recommendations to the organization in what we think should maybe improved, or what should further be clarified, to our opinion. So we can have different perspective on this service performance. Obviously, there's a service perspective, a user perspective. I will elaborate on the service perspective, but you can also look from a more healthcare systems perspective. So let's look into the user perspective. So the positive elements when someone is in need for care is that the sort of digital platforms, they, at least we looked at, have a sort of proactive outreach. So they are quite proactive in offering their services, giving information, of course, in order to reach their clients, and which is a good thing. If you want to help people and reach clients and make healthcare better accessible, that's a good element. But some concern is about the transparency and the objectivity of the information provided on these platforms. A positive thing, obviously, is the 24/7 access available and the sort of navigation through these platforms if you are in need of care. But on the other hand, it needs digital skills and also sort of literacy in order to make proper use. So we see also that a very young population is using this technology as well, but especially people with a low socioeconomic status or having real health problems and all kind of other social problems are not so prone or elderly in using these technologies.
I'm sorry, we have to speed up.
Okay, yeah. So high responsiveness, no traveling are also, of course, positive elements. An important feature is that most platforms don't calculate cost on forehand, but we see also there are some business models around which the costs are hide in other elements of the healthcare provision. So there's high satisfaction rates, but the outcomes in an objective manner are quite unclear. So from a user perspective, there are pros and cons, and the same applies to a service perspective. And so from a service perspective, they work with centralized data, they collaborate, aggregate data, which is good, but it has some worries on data protection and privacy. We see good caseload productivity in most platforms, but really in the technology used and algorithms, there are concerns about the validity, specificity, sensitivity, clinical validity, predictive value, all the measures you need in these type of algorithms. When it comes to the online doctor, decision support can help a doctor, but it also requires skills from these doctors to judge, have the proper judgment on these recommendations. Often it's not very clear on how these decisions with algorithms are made. Another last element I want to mention is that the digital service, we see that it's remain only digital. So the handover to offline, the real hospital setting or primary care setting, and that's often needed, especially with the complex patients, is often not working so well. So there is a disconnect between the online world and the physical world. So from a healthcare systems perspective, I think the positive side is that it can increase universal digital access. But it also can create inequality and leaving out important groups, especially groups with complex conditions. So what we also see, and what is, I think, a big concern, is that because these platforms connect all kinds of organizations and services together, and they tend to dominate the sort of healthcare system with their access to data, with the different stakeholders connected, you create dependencies, a vendor lock-in, and also given that some of the platforms have so much financial power from investors, which want to have a return on the investments, that one could argue, well, one could have concerns about the dominance, especially on the big tech companies, as what you see also in the US, which is, in the end, is moving towards exploitation of patients rather than helping them. So that also is, I think, a lesson for the future to look how we can balance this from a policy point of view in order that we keep an equal, balanced system. Well, what we find out with the Chinese platform, there are still points for improvement, but it's very promising in how it performs in the Chinese context. Thank you very much.
Dziękuję bardzo. Przedłużyliśmy.
Okay, thank you very much. We've given Nick more time. I didn't want him to interrupt because we see a complete assessment of a system. It's a standard which is now only being implemented, and we can see the first tool for a complex assessment. And the Chinese startup, I mean, it can be hardly called a startup, a company with 300,000 users, was evaluated objectively. Okay, what I noticed in particular, especially Nick, after what you've said, is a very varied pace of socialization. So patients may socialize at a different pace than health providers. So there are disproportions which may lead to negative consequences, but may also challenge us and stimulate interoperability. And I also noted very high satisfaction of users of such an integrated platform, which doesn't go hand in hand with its efficacy, medical efficacy. So let's think for a while. How does it look locally in Poland? So let me begin with Tomek Zieliński. Let me remind you, he's a GP, a practicing GP. So from your perspective, when you see such a complex assessment system, which elements are already in place at home in Poland? Which elements are popular with patients? Which elements are becoming the staple of virtual healthcare, but maybe underappreciated by physicians? Well, right now we are on a crash course of virtualization. We are not using the term virtual healthcare. We tend to use the term telemedicine. Well, you know, if you ask an average man what virtual healthcare is, you know, most people will tell you it's telemedicine, because especially in times of COVID, it's one of the hottest topics back home. So some teleconsultations, so consultations when the patient doesn't have to be physically in the surgery, they have, you know, this has been expanded thanks to COVID. I'm not arguing. I'm happy with COVID, but COVID has added momentum to many solutions. So on the one hand, it's virtualization, and on the other, these are very simple tools that we are using, because in most cases we are using our phone, and the only, you know, virtual thing about it is that the patient is at home and not in the surgery. It's not necessarily a value added. You know, some even argue it's a disadvantage, not an advantage. There are some virtual elements because, you know, some things like referrals or sick leaves or prescriptions are no longer on paper. They have gone virtual. So we don't have paper records anymore. There are no physical interactions of the patient with the nurse, with the doctor, or other health professionals. And this element has largely accelerated. It's also being expanded. There is eHealth Center, which has created an e-consultation website. So, you know, the patient is able to get basic advice via the central system. Well, of course, you come across a random physician, usually providing advice, COVID advice, but not only COVID advice. But this is something we are all using every time and anywhere in Poland. But meanwhile, other functionalities are being added. For example, you can register for an online appointment. And, you know, there are different ways to register. You can use your smartphone app. You can go to an adequate website. And there are also algorithms being developed that enable a patient to report an issue, and later the patient is directed to the right medical professional. An appointment is made for him or her. For example, the patient may receive an e-prescription, and if the patient requests an e-prescription, he or she will be redirected to a physician who on a given day is writing prescription, and they don't have to be at the clinic. They can be located somewhere else to provide even more services. In primary care, we are limited by our contracts with the National Polish Health Funds. You know, there are certain regimes that we have to observe because, you know, not only that, but in many places we have outdated regulations, old legislative framework, which doesn't keep up with the spirit of the times. And, you know, it's a big constraint. Another important thing is telesupervision over patients. These are new functionalities which are constantly being added as part of Zielona Góra agreement. In my province, we have introduced a brand new program called Senior. We are trying to actively outreach senior patients in times of pandemic. Why? Because we want them to stay with us. I know that contact and interactions are very difficult. There are new technologies which are not senior friendly. Not everyone's got grandchildren at home. I know there are seniors who are technology savvy, But, you know, the older you get, the worse it gets. So we contact them to provide teleservices, but we would like to introduce telesupervision as well. There are no such programs in place. It was our initiative and the first program of its kind, which is going to be rolled out on nationwide scale. It will be COVID-19 patient supervision and pulsar to monitor oxygen saturation. But I think the pilot is conducted on a sample of 50 patients, and I know it was kick-started several days ago. But this is, you know, real virtual care. Patients will have a device at home. The device will be automatically sending test results to the platform, and as a result, the patient may be consulted or just supervised. So I'm sure this program will be expanded, but we are still, you know, far behind, away from triaging. We don't have bots that will analyze what the patient is reporting, but medicine and digital technologies have gained momentum visibly. Okay, so to go back to consultations last year, when regulations on primary healthcare and e-consultations were adopted last year ago, the Ministry of Health and the National Health Fund have negotiated that every physician will be spending 2 hours a week on e-consultations. So everything is changed. I know, you know. Okay, and are your patients telling you that we went a bit over the top with going virtual? Everything is on your computer, on your smartphone. I never see my doctor anymore. Aren't parents complaining? Yes, some patients argue they see me often, much more often on Facebook than on real life. I think the transition was too fast. It's not that we wanted to do it. We were forced to do it by the pandemic practically overnight. You know, patients didn't have time to get used to new working methods. Patients are very conservative, and so is medicine. They have a sense that they long for human interactions. And you can't replace personal contacts because you need to touch the patient, you need to talk to the patient, you have to get the feeling. There is a variety of services that we can provide online. You know, what is beneficial for the patient, but I think we will be still longing for interactions with patients, but the pandemic is stopping us in our tracks, because if you're wearing an overall, a mask and a visor, and so is the patient, you know, you can hardly have a direct contact with another human being in your surgery. So what is missing today are reliable diagnosing tools, never mind the cost, but we don't have devices in place that would guarantee that if the patient buys the device, you know, I don't know if the readout is reliable. Okay, so let's ask a representative of patient organization. Are patients ready to gradually go virtual? Perhaps certain things, you know, are justified. Perhaps some things should not be performed by health professionals, but patients.
Dziękuję za zaproszenie. Przepraszam jednocześnie za tą trawę w tyle na początku. Nie potrafiłam sobie poradzić. I to jest dowód na to, że pacjenci jeszcze potrzebują trochę nauki, żeby pokonać technologię. No, ale się udało. Dziękuję bardzo też za pomoc. Jak to wygląda ze strony pacjentów? Nie mamy jeszcze takich dokładnych badań, które by wskazywały na zadowolenie pacjentów. Jak tutaj słusznie zauważył pan doktor, to spadło na nas nagle, tak? Zarówno telemedycyna, jak i COVID. W związku z tym uczucia takie, które mają pacjenci, są troszeczkę mieszane. Niemniej jednak Fundacja My Pacjenci zrobiła badania dotyczące m.in. potrzeb pacjentów w zakresie telemedycyny, bo my cały czas mówimy nie o wirtualizacji, tylko telemedycynie jednak, więc okazuje się, że 40% pacjentów oczekuje jednak zwiększenia monitoringu poprzez telemedycynę, zwiększenia monitoringu stanu zdrowia. Moim zdaniem to jest duża liczba i to jest bardzo optymistyczne, te 40%, tak? Biorąc pod uwagę jeszcze to, o czym tutaj też pan doktor mówił, że no jednak te technologie wymagają douczania się i oswojenia się generalnie z tematem. Ja widzę to bardzo dobrze. Mnie ten procent całkiem duży bardzo cieszy. Ja jeszcze widzę tak troszeczkę bardziej perspektywicznie i jestem przekonana, że teleinformatyzacja, telemedycyna będzie sprzyjać troszeczkę wyrównywaniu nierówności w zdrowiu, których doświadczamy, tak? Ponieważ no, na całym świecie tak jest, w Polsce również, że są całe grupy pacjentów, które są oddalone od ośrodków klinicznych, od ośrodków medycznych, mają trudności z dostępem do lekarza. W wielu miejscowościach poradnie mają jednego lekarza albo w czasie COVID-u w ogóle nie jest w stanie przyjmować i te rozwiązania telemedyczne pomogą te nierówności w zdrowiu trochę wyrównać, ponieważ wirtualne dotarcie jest z pewnością prostsze niż pociąg, autobus albo nawet własny samochód.
Mamy w gronie przedstawiciela Narodowego Funduszu Zdrowia, pana Dariusza Dziełaka, który zarządza komórką innowacji. Panie Dariuszu, wirtualna opieka, ale rzeczywiste pieniądze. Jak państwo jako płatnik patrzycie na innowacyjność w obszarze przez niektórych określanych jako oddalającego lekarza od pacjenta? Jak to wygląda z punktu widzenia produktów refundacyjnych?
Dzień dobry bardzo, witam Państwa. Czy mnie słychać? Chyba...
Tak, doskonale.
Chyba dobrze. Panie doktorze, no co, można na to spojrzeć z drugiej strony, bo pieniądze to już od dawna są w większości wirtualne i nastąpiło to zdecydowanie szybciej niż wirtualizacja opieki medycznej. Myślę, że w wielu przypadkach jest istotna nie tyle forma, co wartość, która kryje się pod tym pojęciem opieki wirtualnej. Udzielanie świadczeń z wykorzystaniem komunikacji elektronicznej jest w Polsce formą dopuszczalną czy stosowaną od kilku lat.
The use of electronic solution is acceptable in Poland legally, and this form has been financed by the National Health Fund for a quite long time. And as it turned out, this has become part of the primary care a year ago, which is quite recent. Pandemic has demonstrated that this was the very last moment to introduce telemedicine. Now we have the e-prescription, and the teleconsultation in primary care surgeries is one of the pillars of medical care during the pandemic. It is financed by the National Health Fund in exactly the same way as physical consultations. So we do hope that in about 1 month and a half, we will have a widespread use of e-referrals. And this was the bottleneck for the system in terms of providing continuity of care, virtual care as well. So in the Polish conditions, funding from public sources will be provided for all the services that are part of the guaranteed services basket. This pertains to many various forms of virtual care. It is also possible to fund some pilot programs. Then, of course, there is always a question of scaling up the pilot projects. That's one of the main problems with pilots. However, we should remember that also there, safety and security is the primary concern. Some people forget that according to legislation in force in Poland, but also elsewhere, medical platforms, systems and algorithms, in particular if they include artificial intelligence components, are medicinal products, so they need to undergo the process of certification. Certification of systems is not so popular, in particular when it comes to 2A certificates. So the question is whether the virtual solutions will resolve problems of healthcare. So my question is, have we already made an inventory list of the problems? Because we know the problems we are facing today. What will be the problems in 10 or 20 years from now? So yes, if we make medical care more virtual, this will certainly benefit the flow of information and exchange of information, because we are dealing with an ocean of data, and without virtualization, without digitalization, we can never find our way, both at the end of the patient and at the end of the doctor. So yes, artificial intelligence will be very useful here. And then machine learning is already been applied by us in order to implement the pilot project that would help us to forecast and prevent strokes. We also have a program in order to avoid the problem of taking too many medicines or too many drugs by the patients, and avoiding the interactions that can be very dangerous for patients' health. It has already been said that virtual care will be introduced gradually, and the first target group will be a generation that no longer knows how to function without a computer or a smartphone with access to the internet. And here we are not only speaking of digital exclusion, because some people of older generations understand questions differently. So if we are to set up a questionnaire online, we have to be very careful, because certain people, when they read a text online, they find it difficult to process this question and to answer it correctly. So for that generation, it will probably be easier to say that for the younger generation, it is easier to convince it that medical care no longer means only medical care provided in physical contact between practitioners and patients. It will be different with an older generation. I went to China last year to Zhejiang. It was a very modern solution that I saw there. Automated registration, face recognition, and there were special e-kiosks which actually made basic tests, sent it to the database, to the GP. I was very impressed. At the same time, I know that to a large extent it was used to qualify patients for traditional Chinese medicine, which from the European perspective is not actually fully fledged medicine. So, but the technological solutions were very impressive. So for Poland, first of all, we will use the virtual solutions for emergency cases where we need to intervene very quickly. So sometimes it requires a contact with the doctor, but adverse events, incidents outside working hours of surgeries, for example, as our Dutch colleague has mentioned. So also for prioritizing patients, for triage, using the elements of artificial intelligence, and also certain systems that are used by patients suffering from chronic disease, so that we can alert doctors when there is a change in the health condition of a patient. And before we conclude, I can say something quoting Henry Ford. Henry Ford said that at the beginning of his career, he always asked customers what they expect, and they always said, "We expect faster horses." And he stopped asking. So we do not really know the true consequences of the changes. One thing we can be certain of, this change will come, also in terms of funding. Thank you.
Okay, so listening to your statements, I got a picture of the actual status quo, a certain stage in digital transformation. Well, patients are more than willing to apply those solutions Dorota has in store. I know we have no time to discuss it, but Dorota has a number of proposals, very advanced potential solutions, which, according to patients, would largely boost the efficiency of healthcare. And they are the living example, the poster example of virtual healthcare. So, as we notice, progress is much faster, and many physicians apply those solutions, while the payer or the insurer is not saying no. So this begs a question. And I agree with Dariusz that certification, and you have mentioned medicinal products as an element, as a constituent of an integrated system, like, similar to the system presented by Nick. But Nick, a question to you. What do you think? Or when you are talking with members of the World Association, do you see any prospects for applying, this system for assessment, for evaluation on a wide scale to support a reasonable, effective and safe development of digital technologies that is taking us towards virtualization? How could such assessment system help us in efforts related to e-health in Poland?
So the framework is just a tool to understand the full, let's say, extent of what you need and how it should work from a wide perspective, and to just have the understanding of what these platforms could offer. So I think it's just one element which could help to create this understanding, and accordingly also how it could fit in the sort of context you're working. But as what we learned from transformation of healthcare systems, including the use of digital technologies, is that you need an integrated strategy. So usually it's about the improvement and change in services on how hospitals, primary care, social care should be aligned towards more person-centered, integrated care. And technology is only a part of it, and it should support this process, but the redesign of the services and implication for rules, regulation, finances, that's the key thing in the process. So if we really want to work on implementation upscaling, we have to approach it from this way. So this framework is just one of the aspects which might be helpful for understanding, but actually in doing, you need a totally different approach.
Dziękuję bardzo.
Well, thank you very much. Okay, I treat it as a declaration that if required, if we need to make the system more objective, a virtual system more objective at all, we have such tool in place, so we'll stay in touch. But our digitization strategy and the strategy for development of healthcare system must be kept in check and, develop on our own to cater to our needs. Did I understand you correctly? Okay, thank you very much. Okay, so we will stay in touch. I would like to thank our panelists. I would like to thank Nick for joining us, and over to the studio. Well, I would like to thank our panelists, and especially Nick Guldemont, who had Gdańsk Medical University in the background. Well, our participants who are following this debate include students of Medical University of Gdańsk, and they are waiting for you, Nick. So hopefully we can meet in December, because I know you will be delivering classes in AI, and I hope that very soon we will see you live.